Hello, good afternoon. Is it working? Okay. All right. So good afternoon. Get started. Let me just see where to click to get it going. There we go. All right, we'll be talking about the role of biologics today in severe asthma management. I don't have anything to disclose. And for objectives, we'll define severe asthma and the prevalence of asthma in the U.S. and in West Virginia. We'll talk about identifying like characteristics and subtypes of severe asthma. We will cover like identifying treatment strategy for severe asthma and to decide which biologic therapy should be initiated, and we'll review like available biologics and mechanism of action. So we'll start with the case. This is a 49-year-old female that was referred after a recent hospitalization for asthma. She developed asthma at the age of 35. That was initially well controlled. She has had like more exacerbation recently requiring oral steroid tapers over the last 5 years, 2 to 4 exacerbation in the last year that require oral corticosteroids. She developed like nasal polyposis. She uses like albuterol inhaler, rescue inhaler on a daily basis, and she has awakening of like at night like twice per week. She also like reports having seasonal allergies. She was an avid runner until recently, and she works with ceramics as a hobby. She works as a healthcare administration, and she's a non-smoker, but she smoked like back in college at parties. She has an identical twin who also has asthma, but not quite as severe. Her home medication, she has fluticasone, solimetrol disc, 550, tiotropium, albuterol, NAPS, montelukast, and she's on prednisone 10 milligram about 7 months out of the year. Her physical exam, her ACT score is 13, and her ACQ is like 2.5. She has erythematous, boggy nasal passages, and her lung exam showed diffuse inspiratory, expiratory wheezing with a good air entry. Significant things on her labs, and her IgE levels were elevated, were like 500, and her RAS screening was positive for dust mite and ragweed. And she had blood eosinophils of about 350, and her FeNO, if you look in the table, it was also elevated. It was like around 145. So for this patient, just to kind of a quick, obviously this is like a severe asthmatic, uncontrolled asthma patient. But just to kind of like, switch is like, how do we define those like severe asthma patient and uncontrolled asthma patient? So the American Thoracic Society and the European Society, they defined like uncontrolled asthma for any patients who meet one criteria of the following on your right-hand side. So if someone with like poor symptoms control with like usually ACT scoring of below 20, or someone with like a frequent exacerbation for at least like someone who uses like 2 bursts of like systemic corticosteroid for like at least 3 days in the previous year, or someone who has a serious exacerbation which actually end up causing hospitalization or an ICU stay or a mechanical ventilation, or even like an airflow limitation of FEV1 of like less than 80% predicted after appropriate bronchodilator withheld. So if someone meets like any one of those 4 big criteria, we can just call them like uncontrolled asthma. And what makes them severe asthma is on the left-hand side, which is basically when patients require treatment on the GINA guideline to actually be on a step 4 or 5 for the prior year. or if they use systemic corticosteroid for 50 or more % of the previous year to maintain their asthma control, or if they have, despite using all those therapies, they're still considered uncontrolled. So the patient that we just presented does meet the criteria of being a severe, uncontrolled asthma patient. Why this is important? Because the burden of asthma is actually huge. So if we look at it from like the US perspective, the prevalence of asthma, it's like even now it's about like 10%. This is like a few years older. So right now it's about like closer to the 10% in terms of the United States. But what interestingly is when you look at it closer in each state, West Virginia comes really, really at the top. So we're actually, when this was actually like done, it was 12.4, but I was like rechecking it. It's like in 2022, we're close to like 14% in West Virginia. And this is for like adult asthma. For pediatric asthma, we don't come as like the worst, like, or the highest, the prevalence. So that's something also to look closely into is like, is it that we're underdiagnosed in the pediatric population? That's why we're not catching them, or we're just like, kind of more some overdiagnosing or mixed diagnosing some other patients and having some overlap that's making us look that we have a high prevalence out of the norm. So this makes us to look like, okay, we have a high prevalence, and West Virginia has like a high, like 14%. But what's the percentage of those patients who have asthma who actually that we need to look closely into, and who actually has those severe asthma? So there was like a Dutch study that they looked into the general population. Then when they actually filtered those patients into the GINA guideline to step 4 and 5, they actually noticed that there's about 24% that actually out of the asthma patient that they are severe. And then when they add poor symptom control, so when they looked at actually some screening, and some some data that actually dropped it to like 17%. And then interestingly enough, when they tried to do a small intervention, such as like good adherence or like inhaler technique, that dropped the percentage to like 3.7. So that makes us think like, okay, out of the patients we see as asthma, the asthma severity ranges between 4% to 24%. But there is a lot of burden on the healthcare provider to actually check who's actually severe patients. Are they actually like symptom control or not? And like, are they actually being adherent to their management? And are we doing enough for them, or what else can we provide to them? And this takes us to kind of better understand the pathophysiology, like the pathophysiology of like asthma. So like over the years, we became like kind of understanding more the pathways for the pathophysiology for the asthma, and more like, the mediator that contribute for airway inflammation. So just to make it simple and look like in terms of like two bucket, or two different group, you can split it into like an early onset allergic eosinophilic asthma, who's like the patients who are actually having extrinsic asthma, who they have like allergen, and they have like, more like those patients who will be like allergic to everything. And then those will be like more susceptible to like ICS and more sensitive to it. Versus like, there is one group who are actually late onset, non-allergic, non-eosinophilic, asthmatic. The question is like how to differentiate between the two, and to actually like also try to phenotype those two patients and like to look into the difference between them. In terms of the mediators, we have like the interleukin that we have more understanding about them in the recent years in terms of like interleukin 4, 5, and 13. And then the eosinophil as being the main type of like reaction that happened there. Another interesting component is like the innate immunity on here is the ILC2, which is another contributor. Those all become more important as we advance with the lecture and kind of like look for the more directed therapy towards specific type of treatment. So under the same kind of like, thing is like the phenotyping and endotyping of asthma, which is, we'll split it into the T2 and T2 high and T2 low. So like once we look into it as allergic versus non-allergic or atopic versus non-atopic, or like, we start looking more into those specific kind of like diseases that like, subtypes that we look into. And one interesting thing is when we shift towards that non-T2 type asthma, that's where it becomes a little difficult to treat those patients, because those are the patients that you're going to be giving them everything, putting them on all different inhalers. And like, there is something that's not going to be, they're still going to be like requiring oral corticosteroid. They're still going to be back into the hospital. And that's basically here around, most important around those smoking related neutrophilic asthma. So there is like some overlap here where like those patients, like, some of them are like, like non, like kind of eosinophilic type reaction, as well as maybe like some overlap with like COPDers, smokers. But those are the population that we want to also like, pay close attention to, because they will benefit from like, further like that, like dissecting them into phenotypic and like looking for like other options for them. So 70% of severe asthmatic associated with persistent elevations in markers of T2 inflammation. So the majority of them, they're going to have high T2. Eosinophil levels more than 150 is associated with increased likelihood of response to the anti-2 biologics. And we typically like, when we run our like, workup, we're looking for a CBC with DEF to look for eosinophil count. We could obtain like a sputum eosinophil, but usually clinically it's not doable. It's more for like research. And then there is a total IgE, the FeNO, RAS testing, and BFT with bronchodilator. That's usually where we start, and that will give us like a good idea to kind of help to dissect and phenotyping those patients. And just to kind of give a small 2 seconds about the role of FeNO in diagnosing the management of asthma. FeNO can be used like as an adjunct testing if the diagnosis is usually like uncertain. It's usually like, targeting the activity of interleukin 13 and 4. And more importantly, it's useful for like asthma management. So it helps like into following the disease activity, and actually also useful in like, seeing if the medication helping like with regular testing, you can actually see if the medication is like, working or not. However, it's not in a standalone testing. So like you can't just like rely just solely on FeNO. So you can't use it like in like, in some setting and just be like, okay, just based on this, it's this. It's kind of like another objective data that we can use in order to help us kind of have a better assessment. But one important thing to consider is like what could affect your FeNO level, which is usually you should pay attention if the patient has been on ICS, they've been actually a smoker, which could decrease the level, or if they're like having allergic sensitization. Also, cutoffs for that should be adjusted based on different ethnic groups and comorbidities as well. So prior to initiating biologic therapy, so the patient that presented initially is a patient who's severe. He's on a maximum, she's on like maximum therapy, and she's uncontrolled. But before we commit her to like starting biologics, we want to go back to our basics, which is basically like, do we have an optimized management for her asthma? And that goes back to kind of like just review quickly the SMART and the AIR, like kind of like, from the GINA guidelines. So like basically having a single inhaler as a maintenance and a reliever. So you can use ICS formoterol as an everyday maintenance and as a reliever as well. It's only used in the combination of ICS formoterol inhaler only. Non-formoterol like LABAs in combination with ICS cannot be used as a reliever. The other option is the AIR strategy, where we can do an ICS with a rapid acting bronchodilator, which include like an ICS SABA. This has been updated in the GINA guidelines since 2019. So under the reliever, you will see like ICS formoterol can be used as needed. And even on the alternative, you can see like, ICS SABA as well. It's important also to look at the steps and see if you are actually maximized. You are on like, ICS and a LABA, you are on a high, medium to high dose, you are adding a LAMA, and you still not getting control after that. So alternative strategies, as I said, other than the ICS formoterol, is just having ICS SABA versus the Batrix. And the reason why we have all these in the GINA, it describes it very adequately, like in terms of like, oh, these multiple ways. And if I go to the next slide, this will be like very good, like because one of the issues when you look at those patients, when you assess them, is insurance coverage. So it's usually harder to like which inhaler you can actually get them, and are you able to get them the one that actually meets their like need and all that. So usually you want to have a baseline maintenance regimen. So you have a good regimen that actually maintain the baseline, and you want to have a good reliever that actually like be optimized. And then you want to actually address like, okay, is this patient able to handle, like for example, if they are in the Batrix using like a baseline and like an ICS and a nebulizer and a reliever, then they're going to have a multiple inhalers and a nebulizer, and if it's an elderly, they're not going to be able to keep up. So it's always important to put all that together in order to make sure that the patient is, whatever we're prescribing, the patient is able to actually do as well. So just an update on the case, the patient has been transitioned to the smart therapy with the tiotropium, and her symptoms remain uncontrolled. So then what's the next step? So then we're going to go to the biologic therapy. So biologics has been around as back as 2003. That's when the first one came out in the Xolair. And then we have been actually discovering more and more in terms of like, different targets, and like in terms of like, what actually it has been like coming as more like targets that we can provide. So the targets are the IgE, interleukin 5, interleukin 5 receptor, interleukin 4 receptor, and the TSLP. And we can go like over them one at a time. So for the anti-GE pathway, that's the Xolair, and it blocks the anti-GE. This like the omalizumab study that was published in 2011. I wanted to mention this study. There is a lot of studies. It's the oldest biologic that's been around. It's been around since 2003. And there's a lot of studies on it. This one in particular, it looked into 850 patients on a high dose ICS LABA with uncontrolled asthma with at least like one exacerbation in the last 12 months. And patient who's been on omalizumab, they actually showed that they had a 25% reduction in their asthma exacerbation. They also looked at about their frequent use of rescue inhaler, and that also showed that they actually decreased the need to use that, as well as their quality of life that was assessed based on surveys that showed also that they had improved in that as well. But what's important is that in omalizumab, it's an IgE blocker, but they looked into 3 different markers, and they assessed about the level of those markers and the exacerbation decrease. So they looked into FeNO, eosinophil, and periostin, which is it's a protein that actually also it shows the eosinophilic reaction. It's increased by interleukin 13 and 4 as well. And what it showed that patients who had a high FeNO, they were 53 more percent to reduce their asthma exacerbation if they're on omalizumab than patients who had a low FeNO. Similar with a high eosinophil count, more than 260, as well as like more higher than Beristain as well. So just to summarize on amlosumab, it was FDA approved in 2003. It's used for moderate to severe persistent asthma. The target we go for IgE 30 to 700. So it has a limit in terms of like, if someone has a very high IgE over like 1500, you don't want to use amlosumab for them because then you have a lot of circulating IgE in the blood, and then you won't be able to like, block them. So this is probably not the right biologic for it. You want to have also a positive allergen skin test prior to, or a specific IgE to perennial allergen prior to starting. It also approved for a chronic urticaria and a chronic rhinosinusitis as well. Omluzumab has been shown between all the studies to reduce exacerbation and improve control in adults and children with severe uncontrolled allergic asthma, specifically in that category group that we mentioned, which is the FeNO of over 20 or eosinophil count of over 300. They should have like, robust response and decrease exacerbation. Effect on lung function in terms of like FEV1 in a clinical trial has been small, even like in high biomarker group. And usually the way we prescribe like amlosumab is based on the IgE level and weight as well. So we dose it based on the weight and the IgE. The next group is the interleukin-5 and interleukin-5 receptor pathway. So if this has like multiple agents under this group. So now between 2003 until the next one is actually this one came in 2000. The next one came in 2015. So there was a long time where the next biologic actually came out. So until like 2015, we only had an anti-IgE. And then after we understood like better, like, the pathophysiology and all those pathways, and these clinical trials started coming up, and like we start having all these different options and different like, cytokines that, or like interleukins that we can block. And that just like kind of opened up one after the another. So the first one was meblouzumab. As I said, it was approved in 2019. There was the DREAM and the Columba, trials, but this one, the one I mentioned, is actually an extension of that. So what it shows here on the graph, the initial one right here, it basically shows you like the initial study showed that there is, in the orange here, there is a decrease in the exacerbation for patients who's been on amlosumab. But then this study actually followed them all the way to 156 week further. And it showed even further more decrease in their exacerbation. Those patients, they also showed improved in their ACQ questionnaire. And this study also showed that meblouzumab was successful at actually suppressing the eosinophil count. So the eosinophil count stayed actually low and improved their FEV1 function. The other one is benralizumab, which actually, so benralizumab blocked the interleukin-5. Benralizumab blocks the interleukin-5 receptor. This one, for this study, this one was approved in 2017, I think. But this study, what it looked at is two things. Is like, one is the eosinophil count for patients who are on benralizumab, and patients who had like eosinophil count of more than 300, they showed like, decrease in exacerbation versus like, the one who had less eosinophil count. But another thing also to notice here, that the decrease in exacerbation of about like 51% was more significant a little bit like than 45 with the Q8 actually dosing versus the Q4 dosing. In terms of the FEV1, there was also increase in the FEV1 in terms of like the Q8 dosing and the Q4 as well. So under the interleukin-5 pathway, there is like 3 agents. There's mepluzumab, pembrolizumab, and risluzumab, which is the only IV agent. They're USDA approved for like moderate to severe asthma with like an absolute count of like, eosinophil for like 150 or above. Mepluzumab can also been also approved for like EGPA with a dosing of like 300. Mepluzumab for a chronic rhinosinusitis with the nasal pulposis. But Dupixent is the first line for that. Um, these are monoclonal antibody that binds and inactivate interleukin-5. And as I said, like, pembrolizumab actually acts to the receptor. Anti-interleukin-5 biologics, they have been shown to actually reduce exacerbation by about 50%. They improved FEV1, quality of life, and they reduced actually the need to use oral corticosteroid in patients with like severe uncontrolled asthma who have like eosinophil count of like over 150. So the next group, it targets the pathway of interleukin-4 RA receptor. Sorry. So this one is Dupilumab, and this one, like, the receptor is on the eosinophil. It works on the smooth muscle, and Dupilumab like works on actually blocking this. The This one was approved in 2018. The study was the Liberty Asthma Quest study. It looked actually at 2 different dosing for Dupilumab. It looked at 200 milligram every 2 weeks and looked at like 300 milligram every 2 weeks. They both had like significant, like, reduction in exacerbation, especially in those patients who had like, high FeNO and also like had a high eosinophil count over 150 and even like, over 300. So the guideline is that usually we use the 200 every other weeks. The 300 is usually reserved for patients who are on like steroid dependent or who actually has also concurrent like atopic dermatitis. Another point in the study, it has showed that the glucocorticoid, like the need for oral corticoid, like, oral corticosteroid, like has been decreased with Dupixent, and it was like, very significant, as well as like there was a significant increase in their FEV1 function. So to summarize, for Dupilumab, it's used for like moderate to severe eosinophilic asthma with an absolute count of like, 150 eosinophil, or patients who are actually on oral corticosteroid dependent asthma. It's been recently has been approved also for eosinophilic COPD for patient with like eosinophil count of like over 300. And it's approved for atopic dermatitis, chronic rhinosinusitis with nasal polyposis, eosinophilic esophagitis, and prurigo nodularis. So all the studies on Dupilumab has shown that it reduces the exacerbation, oral corticosteroid use, and improves lung function in patients with like severe asthma, independent of like the T2 like biomarker selection strategy. So one thing about the Dupilumab is that like it just like, the exacerbation was decreased, like, regardless of the actual like, marker. Only T2 biologic that actually associated with a decrease in FeNO and IgE and actually increase in blood eosinophil. So for the Dupilumab, because it blocks the interleukin 13 and 4, so that usually helps with like, migrating the eosinophil and also like, recycling it. So that's why sometimes when you start patients on Dupilumab, you will notice like a spike increase in the eosinophil count initially, but that should like, level off. And usually, as I said, it actually inhibits interleukin 4 and interleukin 13. signaling. All right. The last pathway is TSLP. TSLP is a little bit like more unique than the rest of the other interleukin down here. Because if you see all these agents that we've been talking about so far, they're more like down, like, in the cascade. So they're more at the bottom versus this tispilumab or TSLP, what we're blocking here is more upstream. And actually for TSLP, it's more on like, on the humoral, like, kind of immunity. So it's more upstream and also blocks a little bit different pathway than the others. And it blocks the interleukin C2. Why is this is important? Because when we talked about the T2 type inflammation and about like, having non-allergic type, so this is the pathway that kind of like more thought that may be contributing to that non-allergic type, non-eosinophilic, like, asthmatic. So the idea is maybe this would actually provide a little different approach to kind of blocking and help those patients who have like uncontrolled asthma. And the study for tispilumab has been published in the New England Journal in 2021. If you look across, like, in terms of like the initial overall population over here, it showed that about like over 50% reduction in their like exacerbation. And then if you look at the eosinophil count, despite of the eosinophil count, they were all significant in terms of like dropping the exacerbation as well. However, like, it's more prominent if you have a higher eosinophil. So we know the medication works better if there is a high eosinophil count, but it does still work even if the eosinophil count is lower. So it was approved for like moderate to severe eosinophilic asthma. It did not require like a minimum level for like a blood eosinophil or a FeNO. It's been approved also for like allergic and non-allergic type of asthma, and it reduces the exacerbation and improves lung function in patients with severe asthma. It has a larger impact in patients with the higher absolute like eosinophil count, as I mentioned. So just to go back to our case, giving the patients like severe asthma and the nasal polyposis, decision was made to actually initiate the patient on dupilumab. The next step for this patient, it would be actually to follow them up in the next 3 to 6 months for a trial on dupilumab and see if they actually effective or not. If they are ineffective after like 3 to 6 months, you can try an alternative biologic agent. Once the asthma control is achieved, you can start tapering and discontinue like the oral corticosteroid. We can consider reducing ICS therapy, and this line comes from the SHAMIL study. This study was done on benralizumab. They were able to actually reduce the ICS formoterol, like the ICS like intensity dose without any significant exacerbation, and then we were able to like taper it down. However, the patient still should stay on ICS like on a high on ICS like LABA, because otherwise the insurance won't continue to approve their biologics. All right, so just to kind of sum it up, what's important in patients who coming in with like severe asthma is, one thing is patient selection. So it's very important to actually confirm that that the patient has like moderate to severe asthma, and actually try to have like, okay, those are the patients that I need to maybe like look closely into them, or like kind of like see if they are of it, like what else can I actually provide for them. which takes us to the next step, next point, which is eligibility for biologics, meaning like, doing phenotyping on those patients, seeing if they do have like, high eosinophil count, like do they actually fit like the allergic type asthma, the eosinophilic, or they're actually non-allergic, or do they actually have some overlap syndrome or something that actually also concerning and like open the door for them to be eligible for biologics. It's also important to optimize their baseline therapy. It's important to look for comorbidities and like see if there is like anything underlying that's actually contributing into their like uncontrolled asthma, such as obesity, GERD, or like, anything else. And also important to actually like, refer and the referral and consulting timing. So if you feel like you can identify all these bullet points and like kind of like you see like, okay, I have a patient who like, have like a severe asthma or like moderate to severe, then like, probably like referring them to us, like, so we can actually like, look at them as early as possible. And collaborative care. So collaborative care actually is very important at both inpatient and outpatient. So from the inpatient setting, it's very important to have a good collaborative care between like, departments. So having like an early consult for like the pulmonary team to kind of know to identify these patients, like when they're in the hospital, so they can actually get followed up and actually try to actually have a better management for them so they don't get like, keep coming back into the hospital, as well as an outpatient as well. Because like once we start the biologics, it takes like, time and months to actually have the therapy. So it's good to have like a good communication and making sure that like, everybody's on the same page on that. It's important to monitor the response and adjust. So like, as we said, 3 to 6 months, if the therapy is not working, then we need to actually look for different agent. And patient education. It's important to involve those patients. So like, for example, like, we've been trying to start the obstructive lung clinic, which actually has the COPD and asthma underneath, which this takes me also to kind of combine the two together, where there is a lot of like, overlap as well. So it's important to have like, the same way we have like, COPD action plan, we have like, asthma action plan. We need to have like, better education to the patient so we can actually have them follow up with their like outside, like, doctor and like, have them better optimized. And that's it. Any questions?
Witnessed a remarkable progress. In terms of complexity, where do you think is the cutoff where something that there's phenotype? On one end, there's phenotyping, but on the other hand, there's underutilization biomarkers.
Mm-hmm. Yeah.
Part two versus that happens patients that are in the clinic, and if you're taking care of them, especially in context of West Virginia. West Virginia, we have the highest asthma.
Yeah.
then on the other hand, you have the ICU.
Mhm.
And then which nobody has ever. That's very complex because some people have used it. You should not be put in those situations necessarily.
Yeah.
This is a very complex. How do you address this?
So for the first question, yeah, very good point. So I think the early on, like, referral and being involved is actually good. And also, like, the level of comfort. So I think, like, as we mentioned, like identifying those patients that they are actually severe and they might be actually, like, needing a little more. Um, I think the early you refer them to like, to us, like, it would be actually better to actually get them phenotype, as you mentioned, and then have them started on the therapy. So they're not being, like, back and forth into the hospital, or, like, being added on like multiple courses of like on steroid. So I think, like, to start with, like, maybe education about, like, knowing that, like, kind of that this is available for the provider and all that. So we can actually, like, be in service in order to actually, like, provide that. So I think the early on you recognize that you are dealing with, like, a patients that whose potential to have, like, moderate to severe COPD or asthma, then an area referral should be, I think, sufficient in order to actually have them better assessed for the first question. In terms of the second question, I think, yeah, it's a huge in terms of, like, what I noticed in my short 6 months in West Virginia. Like, that actually, like, yes, there is a huge, like, overlap between, like, the asthma and COPD, and we have the number one in both. So I think there is a lot of, like, stuff that, like, needs to be worked on in order to actually continue to improve. There's a lot of room for, like, finding those patients and actually, like, trying to optimize their management. Um, so one way we're actually working on that is we're expanding with our pediatric department. So I've been actually in connection with the pediatric, like, asthma team, and they done, like, amazing job. And their end, like, they actually to have, like, established their asthma action plan and all that. And one thing we came out, like, we've been thinking about is like a transition clinic. So that's one thing, is between pediatric and adults, to kind of try to see those severe patients and moderate patients so we don't lose them. So that's one area that can actually be improved. And the other area that you mentioned is actually having that transition from inpatient to the outpatient between those asthma COPD patients that, or maybe in between. As I said, we do have an asthma action plan, we do have a COPD action plan, but we don't have an overlap action plan. So maybe we should have, like, a bigger umbrella, which is an obstructive lung disease that fits COPD and asthma underneath, and actually have a better transition once those patients get, like, flagged that they're getting admission, like, multiple time, or being on steroid multiple time, that they can be referred, and then they can be looked into and getting phenotyped, and yeah, better.
So how could I, as a trying to get
So the clinic is in the POC, and the usually, like, the referral, the same way I think, like, you refer for, like, ILD, you can refer for, like, the obstructive lung disease. I think I'll be working with Bethany just to develop, like, probably a better like, yeah, yep, as a refer to coastal, yeah. Yes. Yeah. So in terms of deciding which factor, that comes into the phenotyping. So you have to look into, like, each patient individually and see, like, okay, is it, like, predominantly, like, IgE, and, like, do I need to go with, like, Xolair versus, like, if it's like someone who's on oral contraceptives, but then their markers are normal, then I probably more for Dupixent, versus like, a third like patient, who has like high eosinophil count, and then they can be on like Nucala or Mebluzumab, right? So that comes where like you have to be a little more, like, to dig deeper into the phenotyping, like, so in order we can actually choose the right medication for them. And then after that, you're going to do the trial for 3 to 6 months. And then, because sometimes you will have two options that you can actually choose from. So you will just pick one and then like, you go for. So that's in terms of the first question. What was the second one? Sorry. Oh, the risk factors for, yeah. So I think like I don't know, there's like multiple theory, maybe like, I don't know, like being overweight is like maybe one that plays a little bit into it. And also like probably like a lot of the exposure. There's a lot of like, coal mining, a lot of like, a lot of patients like, like their exposures in at work or occupational. Probably that also playing into the asthma. But that's something, yeah, that's something interesting to like, yeah, see. But as Dr. Sharma said, like we're high in both in COPD and in asthma. What's surprising is that the pediatric population is not like, it's more like in the adult. So I'm not sure if like, and that's what when I was kind of talking to our pediatric colleagues, is like, that's what they noticed, that there is a lot of like need for education. So that's what they've been trying on to educate about asthma, like, go over, because that's also another big factor in terms of risk for like, asthma. So I think there's a lot of like maybe underdiagnosed or not diagnosed. So that's why we don't see them as like until like, later, or like, they're just being missed. Yeah. And smoking is very high. Yeah, for sure.
The comment slash question, a lot of the research and presentations on that always have like allergy, immunology,
Yeah.
ENT, pulmonary together. This unified airway concept where the nose and the throat is all kind of connected to what the lung does, vice versa with the polyposis, the rhinitis,
Mm-hmm.
urticaria, the asthma stuff. Is there a way that we can move forward and come together with these specialties? I know allergy, immunology treat that, but we treat that, but ENT also started to pick
Yeah.
up their patients, and inevitably helps with their asthma too. So is there a way we can work together and treat it as
That's not a bad thought. Yeah, like I had one of the allergy immunology like fellows in the clinic the other day, and we were talking about it actually. So I think collaboration at any level is actually great. So like, yeah, if I think it would be a good to actually have good collaboration with like any other team. Yeah. Oh, there is something in the chat. Sorry. Says thank you. It's Dr. Al-Jaroushi. Thank you. Man, my voice was like going.
Oh, yeah.
I was,
You glad you had the water.
thank God that saved me. I was like,
Everyone gets it. We don't want to separate work.
I know, right? Thank you so much.
Thank you. Very much a pleasure working with you. Everything, you just got everything to me right away.
Thank you.
Thank you.